is Dr. Dorcas Chomba. I'm an orthopedic surgeon from Kenya, and I'll be taking you through radial head fractures. This is my only disclosure. This is a local company. This is a brief bio of myself, and this is an outline of how we'll discuss the radial head fractures. So we'll start with normal anatomy. So of relevance to radial head fractures is we have the distal humerus, which flares out distally. On the medial side, get the medial epicondyle. On the lateral side, the lateral epicondyle. And on the epiphyseal end, on the medial side, is the trochlea articulating with the ulna. And on the lateral side is the capitellum, which articulates with the radial head. Running down the neck and the proximal radius. On the lateral side, what is important is that the capitellum sits about 30 degrees anterior to the humerus. You know that the capitellum is convex in shape and it articulates with the concave aspect of the radial head. Also, what you need to remember is that this view on X-ray will overlap, so it's important to be able to outline the bony continuity with the appropriate articulating surface so as not to miss a dislocation. Other important structures are the radial tuberosity, the radial notch, which articulates with the radial head, and the coronoid process, which is part of the ulna. So as we said, on X-ray, especially the lateral view, should be able to follow the capitellum about 30 degrees anterior to the humerus. Its convex aspect articulates with the radial head, and the trochlea articulating with the ulna. So you must be able to make sure the right bone is articulating with its correct distal partner. Otherwise, you'll miss a dislocation. Why I emphasize this is this happened recently in our unit. The person who saw the patient initially thought there was no dislocation, but when we reviewed the X-ray, we could tell that the capitellum was actually not articulating with the radial head, and there was a subtle dislocation. They couldn't get proper views because of pain, so I think that's why they only had one lateral view. That's why this was easily missed. The basics of the elbow joint in general is the elbow joint is a hinge joint, which means it allows motion primarily in one plane. It's lined by hyaline cartilage. It's a synovial joint with a capsule enclosing it. And the capsule is thickened medially and laterally to form the collateral ligaments. There are several bursa around the elbow joint, and this is help to reduce friction of the moving parts of the joints. The other soft tissue structures of importance is the anterior and posterior fat signs. More specifically with the radiocapitellar joints, this is a pivot joint, which means it allows for rotational movement. As we say, the capsule is thickened to form the medial collateral ligaments and the lateral collateral ligaments. As you can see on this image, the green is the joint capsule, the blue is the annular ligament, the red is on the medial side, which is the medial collateral ligament, and the yellow is the radial collateral ligament. So if we look at these structures even more detailed, is that on the, let's start with the medial side. On the medial side, the medial or ulnar collateral ligament is actually 3 bands, anterior, posterior, and the oblique band. And on the lateral aspect, the lateral collateral ligament is actually a complex made up of the lateral ulnar collateral ligament, the radial collateral ligament, the annular ligament, and this around here should be the accessory lateral collateral ligament. With this sagittal cut, I want us to note where the fat pad is. So you have the posterior fat pad and the anterior fat pad. This will become relevant on assessing on X-ray whether you have subtle fractures. We'll discuss more on that as we look at the X-ray. More details around the radial head is the blood supply to the radial head comes from the radial recurrent artery and the interosseous recurrent artery. The radial head is actually a disc. On the top surface, it's concave, covered with articular surface. Then there's the rim of the disc. Part of it is covered by articular surface, about 280 degrees of it. Then there is a portion of it that's not covered by articular surface. This is what we are referring to the safe zone. It's about 90 to 110 degrees. This region can be outlined by drawing a line from the radial styloid, sending that to the radial head, and another line from the Lister's tubercle and extending it all the way to the radial head. This area has little or no cartilage, so it becomes, that means it's also non-articulating, so it becomes a good zone to place your implants, either the plates and the screws, without interfering with the articulating surface. Radial head fractures account for about 1 to 4% of adult fractures and about 20 to 30% of elbow fractures. It's most commonly seen between the ages of 30 and 60 years. The mechanism of injury is commonly fall on an outstretched hand. So the arm is extended, the forearm is pronated, the forces will ripple through the radius, impacting the radial head, the talum. Some occasions, it's a direct blow to the lateral aspect of the elbow. This is those who watch football, this is how Messi injured his radial head. The presenting features, so the patient will complain of pain around the elbow with associated swelling. They may be unable to extend and flex the elbow joint or have worse pain with some of the motions like pronation, supination. And when you examine the patient, there may be obvious deformity in case there is associated dislocation, or you may just see swelling with bruising or ecchymosis around the elbow. On palpation, there will be tenderness, especially on the lateral aspect of the radial head and neck. And we attempt to moving the elbow, either both active and passive motion, the patient may experience pain. Radial head fractures may be associated with ligamentous injury. So whenever possible, it's good to assess for a stability around the elbow, though this might be difficult in the acute setting because of pain. All the neurovascular structures distal to the elbow should be assessed, both the radial and ulnar artery, the radial, median, and ulnar nerves. Of note is that Bolstra and his colleagues demonstrated that there was associated posterior interosseous nerve palsy with close proximal radial head and neck fractures. So what next? You listen to the history from the patient you've examined and you suspect that the patient has a radial head fracture. Then you order for x-rays. So what are you looking for in x-rays? So the common views that we use to assess the elbow joint is an anteroposterior view, a lateral view. Sometimes all you may see on the lateral view is a fat pad sign. We'll see one here. These are not present on a normal x-ray, as you can see on this x-ray, which is normal. But when present, either an anterior fat pad sign or a posterior fat pad sign, that may be an indication there is a fracture, including a fracture of the radial head and neck. As you can see with the simple lateral view, there's usually an overlap formed by the coronoid over the radial head. This may mask a subtle fracture. So to be able to visualize the radial head more clear without the overlap from the coronoid, you can request for a Greenspan view. So the ABC is A for alignment. Make sure you do not have loss of alignment between the articulating surface. B is for the bony outline, so check for any cortical break. CS is for cartilage and soft tissue. So in this case, the soft tissue structures that may alert you to a radial head fracture is the fat pad sign. A lot of times, x-rays are all what you need to be able to decide on the way forward in terms of management of the radial head. If you have access to CT scan can be very useful, especially if you are suspecting a radial head fracture, but you're not able to see it on a plain X-ray. In case you can see a radial head fracture, CT scan gives you a better visualization of the intra-articular involvement. As you can see here, you are able to see the orientation of the fracture lines, hence plan how to apply the plate and screws. MRI is only indicated when you suspect associated ligamentous injury. There are two classifications that are commonly described around the radial head and neck. One is the EO classification, and the second one is the Mason's classification. The Mason's classification is the most commonly used classification, and this classification was designed by Mark Mason in 1954. He only described type 1, 2, and 3. Type 4 was later added by Johnston in 1962. And later on, Hotchkiss modified this classification to better define the need of surgical management. So a type 1 Mason class fracture is a fracture through the radial head or neck that's minimally displaced, and the cutoff is 2 millimeters. Type 2 is a fracture that is more than 2 millimeters displaced, and there's involvement of more than 30% of the radial head. A type 3 fracture is a comminuted fracture of the radial head and neck, and a type 4 fracture is a radial head neck or neck fracture associated with a dislocation. Like with any trauma patient, the first thing is to ensure that any life-threatening injuries are sorted out, and this follows the ATLS protocol. Once life-threatening injuries are sorted out, then you follow to sort out any limb-threatening injuries, any vascular injury, any compartment syndrome. As part of the emergent care, give the patient analgesics, splint the limb, And if it's an open fracture, follow the open fracture protocols at your facility, and this usually include irrigating the wound with either normal saline or clean running water. Rest the wound, take a photo so that you don't have many people having to expose the wound just to see it before the patient goes for debridement, and start early antibiotic, broad spectrum early antibiotic. If there is associated dislocation, like what you would see in a type 4 Mason injury, then the dislocation needs to be reduced as early as possible. Once the emergent care has been given, then you proceed to plan for definitive management. So part of the planning is to take a good history, examine the patient, then order for the appropriate imaging and other relevant investigations. Plan the surgery as per the classification of the fracture, and available equipment and expertise. In case you lack the expertise or the required equipment, then it is best to refer the patient to the appropriate facilities. I find the AO principles of fracture management very useful for all fractures. And in the case with the radial head, the first thing you want to do is make sure that the fracture is reduced and aligned. Being an intra-articular fracture, you're aiming for anatomical reduction. The second principle is to ensure you have a good stabilization. The third principle is to make sure you preserve soft tissue and blood supply to the fracture site. The fourth principle is appropriate rehabilitation with early range of motion. Following the Mason classification, so as we said, Hotchkiss did modify this to better define the need of surgery. So Mason 1 is usually treated non-operatively. So this could be a cast or a slab or something as simple as an arm sling. Mason 2 may be managed conservatively unless there's a mechanical block with instability, and this will require open reduction and internal fixation or excision of the fragment if it's too small to be fixed. If there's mechanical block with instability, then the fragment needs to be fixed and the ligaments reconstructed. A Mason 3 usually is indicated that the patient has surgery. This will include open reduction, internal fixation with either plates, screws, or screws only, depending on the size of the fragments. If there is instability, then the ligaments need to be reconstructed. If the fragments are too many that they cannot be fixed, then you can excise the radial head. If you do have the radial head replacement available, it's advisable to do excision and replacement. If it's not available, then excision alone can be done. If the ligaments are unstable or torn, then ligament reconstruction needs to be done. With the Mason 4, which is a radial head and neck fracture with a dislocation, then reduce the dislocation, treat as a Mason 3. So these are the options we've discussed. For non-operative management, you can do a cast, you can do a slab, a brace, or just as something as simple as an arm sling. A lot of times you don't need to do a full cast, and an arm sling alone may suffice. For the fixation, you can do a plate. Remember to put it on the safe zone as we discussed earlier. Sometimes you can do screws only, headless screws, depending on the configuration of the fracture. If it's a type 3 that you're not able to fix, you can do excision of the radial head or excision and replacement of the radial head. There are several approaches that can be utilized to approach the radial head. Common ones are Kaplan, focus. There's also a Boyd's approach. So the Kaplan utilizes the interval between ECRL and EDC. The Coker's approach is between the anconeus and the ECU. And the Boyd's approach is between the anconeus and the ulna. There is another approach that has been described, the Wrightington's approach. The Wrightington's approach also uses this interval between the anconeus and the ulna. The only difference between the Wrightington's and the Boyd's is that the Wrightington's, the surgeon will perform a supinator crest osteotomy. Sometimes getting this interval between the ECRL and the EDC can be difficult, so some people do an EDC splitting approach. All these approaches have pros and cons, as you can see from this view. The Kaplan's takes you very close to the posterior interosseous nerve. The Coker's takes you through the lateral ulnar collateral ligament. And as we said with the Wrightington's, doing the supinator crest approach, that does put you at risk of either getting a non-union of the osteotomy or radioulnar synostosis. Roller and colleagues have shown that arthroscopic treatment of fractures of the radial head is possible with good outcomes. So comparing the different approaches, so the Kaplan's approach does give a larger surface area visibility of the proximal radius compared to the Coker's, and this was shown by Barnes and colleagues. In terms of posterolateral instability, Karalambous compared the Wrightington approach with the posterolateral approach, and their conclusion was that the Wrightington approach is more superior to the Coker's approach in terms of stability. David and Blona did cadaveric demonstrations. And what they did is they started with the Kaplan's approach, and once the radial head was exposed, they tested for posterolateral instability, and there was no posterolateral instability with the Kaplan's approach. Then they did, on the same cadaver, the contralateral side, they did a Coker's approach. And as soon as they exposed the radial head, they assessed for posterolateral instability, and they were able to show that there was posterolateral instability with the Coker's approach. The other thing to consider when approaching the radial head is posterior interosseous nerve. Diliberti and his colleagues demonstrated that the posterior interosseous nerve is safest with the arm in pronation when doing the radial head approach, although this doesn't quite apply when using the Boyd's or the Wrightington's approach. Once you've fixed for those patients that need surgical management, or you've applied the splint or an arm sling for the nano management, that is what will guide the rehab protocol. But with the elbow, it is best to obtain early range of motion, as this reduces the risk of joint stiffness. Some of the complications we see around the radial head and neck will be surgical related, infection, injury to the posterior interosseous nerve, loss of implant fixation, or elbow instability. Non-union, where the bone does not unite, or malunion, where the bone unites in an unsatisfactory position. Trophic ossification is also a concern. osteoarthritis, early osteoarthritis or secondary osteoarthritis, as this is usually an intra-articular fracture, is also of concern. Elbow stiffness and loss of forearm rotation. Radial synostosis is also of concern, especially with the writing tone approach, where you do the supinator crest osteotomy. In case of radial head excision without replacement, the Essex Lopresti injury is of concern. Remember, the radial head is the primary stabilizer of longitudinal forces around the forearm and the elbow. So with the loss of the radial head, really the radius shortens, which results in distal radial ulnar joint disruption. These are some of my references. Thank you. Any questions?